Very good evening to all, and welcome to Iylon Precision Oncology Symposium, the first of its kind and really a first in the series. I am accompanied by my colleague, Dr. Sendurai Mani and Dr. Padmaja Ganpati. I welcome you all to a wonderful evening full of academic feasts. And now I hand over to Dr. Mani to take it further. But before I do that, I would like to give you an introduction for who he is. So Sendurai Mani is known to many of us, people who are attending this conference. He's friends with a lot of us, but some will not be familiar with who he is. And he is truly a star. He is the force behind Iylon Precision Oncology. Formally, Sendurai Mani is a professor in the Department of Translational Molecular Pathology at MD Anderson Cancer Center. He is a co-director of the Metastasis Research Center, as well as the Center for Stem Cell and Developmental Biology at MD Anderson Cancer Center. Mani got his PhD from Professor G. Padmanabhan, former director of Indian Institute of Science, Bangalore. Later, Mani joined Professor Robert Weinberg, a pioneer in cancer biology at MIT Whitehead Institute as a postdoc fellow. Mani was the first to demonstrate that cancer cells can become cancer stem cells by activating the latent embryonic epithelial mesenchymal translation program, EMT program. This finding provides the foundation and explanation for the presence of plasticity within the tumor, as well as the development of metastases and resistance to various treatments. This finding has been cited over 8,400 times, and in fact, very few articles get this kind of citation. For example, based on citation, his paper ranks 86 out of, I can't even read it, 3.3 million articles published in this area of cancer. Dr. Mani's lab investigates the biology and the contribution of EMT and cancer stem cells in developing metastases and chemoresistance. In addition, in close collaboration with Dr. Vivek Subbiah, Dr. Mani's lab is developing biomarkers and drugs to target therapy-resistant cancer stem cells based on precision oncology. Dr. Mani has received numerous prizes and awards for his research, including Jimmy Foundation V Scholar Award and American Cancer Society Research Scholar Award. Last year, Mani was elected as a Fellow of American Association for Advancement of Science, AAAS. This honor is given to very few scientists in the world. Now, first of all, I am honored and privileged to be working as his colleague. I'm really, truly honored to be shouldering this effort, this initiative with Mani. Mani, I request you to introduce the concept of Iylon and introduce our CEO, Dr. Padmaja Ganpati, and welcome our first keynote speaker, Dr. Massimo Cristofanelli, for this evening. Mani, please take on.
Thank you, Sevanthi. That's a kind, nice introduction. Thank you, and thank you for having all of you for making time to join us. First of all, I want to say good morning, good afternoon, good evening to all of you for coming from different parts of the world. Thank you. We have been really touched by the pandemic, which is really going around. If you all don't mind, let's take a moment of silence, just in honor of all those who lost life, and wish this goes away faster, just for 10 seconds. Thank you. Again, thank you all for making time. It gives me great pleasure to kind of welcome all of you to this Precision Oncology Symposium. So I just want to give you a little history about how we got started with this process. More than a year ago, I got a chance to interact with Dr. Sevanthi Limaye, or Sevanthi, about precision oncology. And for those of you who don't know, Seventy, I'm sure the colleagues in India would know Seventy a lot, but those of you who are outside of India, Seventy is a passionate precision oncologist, and she works at Kokilaben Dhrubai Ambani Hospital. She completed her residency and fellowship from New York University, and then she also trained at did a fellowship at Albert Einstein. Then she became a faculty at Dana-Farber Cancer Center, Harvard Medical School. She also worked at Columbia University before moving to India. So when I was talking to Seventy, she explained to me that she gets a lot of her patients. They walk into her clinic with the precision oncology or genomic reports, and her being precision oncologist and following up the literature, she was able to treat her patients well. But at the same time, it's always a good idea to get a view from someone else. With that, she has been approaching her friends from Dana-Farber, from Memorial Sloan Kettering and Columbia, and asking them to do a favor to look at her patient genomic report and give a right recommendation. As we all know, that the precision oncology really revolutionized the cancer treatment. So some time ago we thought that there are patients who cannot be cured or treated or saved. Today it's those, many of them are living for many years. It's thanks to the precision oncology. But again, one of the beauty about an academic science is that we all work together, we all help each other. And so whenever Seventy asks her colleagues and friends, and of course, the doctors in the other end, they want to help. And so is Seventy. So together they were able to do a number of miracles for many of her patients. I'm sure many of you other clinicians and oncologists would do the same. But we thought that, when I was talking to Seventy, we thought that why don't we make this formalized? This way, it would help the patients, the clinicians, and the advisors will not hesitate to provide their input because it's in a legal ground. So with that, we decided to kind of create a team of experts, and almost every one of them we approached were kind enough to join us, and many of them are in the call as well. And we really thank all of our advisors, not only being a part of Iylon, but also providing advice outside of Iylon. Many of them are our friends and colleagues and collaborators, and we thank all our advisors. With that, we formed Iylon, and so then we have been looking for somebody who could kind of work with us, and we were fortunate to find Dr. Padmaja Ganapati, whom I've known for many years, and she is running the Iylon operation as a CEO. And she, just to introduce Padmaja, Padmaja got her PhD from Madurai Kamaraj University, and then she got an MBA from Rutgers University. And she has been doing many cancer-related work, and she's kind enough to join us as a CEO. So welcome you all, and I hope you all will join us in fighting or helping the world cancer-free by joining our team of oncologists, and then working with our advisors and deliver the utmost precise, precision, personalized care to all the cancer patient beyond any country's border, to everyone. So with that, I pass the mic to Padmaja. Thank you. Thank you all.
Thank you so much, Mani, for that great introduction. It's really an immense honor to be on the Iylon Precision Oncology team for me. I've known Mani for over 3 decades now, and I've always admired his indomitable spirit, can-do attitude, and most of all, his service-mindedness. That's incredible. When he first called me about Iylon and walked me through the website, I was just flabbergasted, honestly, by the quality of the advisory panel. And to see all these names in one place itself is no mean feat. And to think that a patient in probably Madurai or Usilampatti is going to now have access to doctors at Memorial Sloan Kettering, that's really shrinking the world into a very tiny ball, and therefore shrinking the cancer as well, we hope. I then met Sevanthi, and honestly, I was incredulous. How could such a preeminent precision oncologist be so humble? Her dedication and hard work, which I've seen since I joined Iylon, will definitely take the company successfully through our vision of serving patients first. And through Iylon's platform, I'm sure you, the clinicians who are all here at this meeting, will be empowered with that ultimate arsenal, the latest of developments, and a chance to collaborate with the best of the best in the field, who with their particular expertise and experience can put together the last piece of the puzzle for our patients. So we are really excited to have you all here today. And I would like to give the mic, so to speak, back to Mani to start the symposium.
Thank you, Padmaja. Mani, please, if you could welcome Dr. Cristofanelli, and then
Yes.
We'll bring in Dr. Senthil Rajappa to do a formal introduction.
Thank you, Sevanthi. So thank you, Padmaja. Massimo was my very good friend. There he is, and I've known him for over 14 years. When I came to MD Anderson, his warm welcome and smile really kind of made me like home. Some of the reasons I really kind of the part I enjoyed at MD Anderson. Now he's not at MD Anderson. We miss him, but he's a friend wherever he goes. So for those who may not know Massimo as contribution, just in one line, I'm sure he will be formally introduced later. He was the first one to show that CT-Caesar can be diagnostic. So I have just submitted a grant application, and in that I have a patient advocate who used to be Massimo's patient, and she's kind of so much devotion to Massimo, and because he saved her life. And that's one example. There are many such, and in every case she's applying precision oncology on top of that personalized touch from the heart to the heart. That is where the Massimo really kind of I'm really kind of felt so connected with Massimo, because the passion to help people, to help cancer patients, doesn't matter where they come from, and the goal is to help. And thank you, Massimo, for joining the advisory board and also kindly willing to give a talk here. So now with that I pass the mic back.
Thank you. Thank you, Mani. Thank you so much. I welcome Dr. Senthil Rajappa, a senior oncologist from Indo-American Cancer Hospital and Research Institute, Hyderabad, to host Dr. Massimo Cristofanelli, and also through his talk, and also moderate the questions and answers after the talk. I just want to say, for Senthil, we have just said he's the encyclopedia, and we all know that. And such a great time to have you here. Welcome.
Good evening, everybody, and thank you so much, Sevanthi, as always, for that very, very gracious introduction of mine. I'm always humbled. It's a pleasure to be here today, and a privilege to introduce Professor Massimo Cristofanelli. He is the Associate Director for Translational Research, the Lurie Cancer Center, Professor of Medicine in the Division of Hematology Oncology, Northwestern Feinberg School of Medicine. Of course, he's a world leader in precision oncology. His area of interest, obviously, is precision oncology in breast cancer. One of his passionate areas of research is inflammatory breast cancer. He's got a special research program in his clinic, and that has finally evolved into an IBC International Consortium, IBC-IC as it's called. He's an expert in locally advanced breast cancer and, of course, metastatic breast cancer too. And he's an authority on new endocrine therapies for hormone receptor positive breast cancer. Today, he's going to talk on precision oncology in metastatic breast cancer, real world data from molecular tumor boards. As all of us know, that is the bottleneck as far as precision oncology is concerned. You've got tons of data, you've got lots of patients, but how to get this data to be implemented in patient care so that it will improve the lives of patients, make them live longer and also live better. And that's what a molecular tumor board is supposed to do. And we've got that topic that Dr. Massimo Cristofanelli will talk to us about. Thank you so much for being here, Professor Cristofanelli, and I hand it over to you to start the talk. Thank you so much.
Dear Sevanti, Mani, and everyone participating to this first meeting of Molecular Tumor Board with our Indian oncology colleagues. Good morning or good afternoon, and thank you for inviting me, for giving me the opportunity to share our experience on precision oncology in metastatic breast cancer, particularly looking at the real-world data generated from our molecular tumor board, how this data really has changed, in some cases, dramatically changed the outcome of our patients. Approximately 5 years ago, we started this precision medicine program called Oncoset, and we want to develop a model based also on other examples in the country, looking specifically at the importance of sequencing, selecting the appropriate sequencing technology or company for partnership in order to get the most reliable objective information from either tissue, blood, or other samples, and to characterize really the biology of the disease. But we also realized very early on, oncologists are not trained to really interpret and implement genomic sequencing, particularly in breast cancer, more, of course, in other tumor types, including non-small cell lung cancer. So we created a molecular tumor board where a multidisciplinary group of clinicians and scientists discuss the reports in order to make actionable. And I think this has been an important part of the Oncoset program. With regard to the treatment, as you know, when you move from the sequencing to the interpretation to the treatment, there are various possibilities. One is obviously the application of treatment for which there is a specific molecular target that accompanies diagnostics, and this list is increasing, and in some cases, even in breast cancer. In other cases, you need to look at full off-label use, or even standard treatment would be the most appropriate. So it's really a process that we are learning to implement in patient care, and is becoming more and more part of our assessment. So the molecular tumor board, we spend a few more words, and then we move on to some of the cases that we have treated successfully. So the process of the molecular tumor board is important. We obviously start from the pathology, review the pathology. For breast cancer would be ductal carcinoma, atypical histology, lobular carcinoma, and so forth, in order to understand what we'll be looking. And of course, the pathology primarily is tissue biopsy for metastatic disease. Sometimes there could be more than one specimen. Then we review the genomics as well as germline testing, and we even look at the cell-free DNA that sometimes is performed at baseline or is performed longitudinal in order to understand the evolution of the disease. So we'll see some examples later on. And then we put this in the context of the clinical and treatment history. These patients have already a history of metastatic disease, have been exposed to treatment in primary and advanced disease. Maybe they have endocrine resistance, maybe they have progressed on immunotherapy. Through this process, we identified targetable mutations, resistant mutations, again, in the right context, immuno-oncology biomarker, and more potential germline alterations that may change the way we assess the patients. And then we look at the targeted therapy that may be appropriate for this patient. As I said, FDA-approved drugs, clinical trial, hopefully, off-label use, and a variety of other therapy, including chemotherapy and standard therapy. So we try to categorize like everybody else has done. As I said, looking at the level 1 evidence for FDA-approved biomarker with match therapy. Otherwise, there is a level 2 expert consensus, a well-powered of studies for use of drug. And I think the majority of the study in breast cancer suggests that when you run an NGS in breast cancer patients, you move from level 1 to level 3 very rarely you look at level 4 or level 5. So there could be some information that could be either relevant, suggesting an association with a mutation, or specific information they may bring to a decision process and indicating which therapy shall be used. So let's look at the clinical cases that have some peculiarity. First of all, we look at cases where there is endocrine-resistant tumor heterogeneity that can be studied very well with the use of cell-free and incidental findings. We look at the molecular evolution versus clinical progression. This is something that is becoming important. It gives an opportunity maybe to change patients' future outcome even more. And then there are some molecular-driven unexpected and opportunities for targeted therapy. Remember that in the NCCN guidelines, by the way, there's been a new version just came out. For breast cancer, there are not many genomic-driven targeted therapy. We all know there are 2 amplifications. We know that now we have a PI3K mutation tumor that can be treated with alpelisib, the first PI3K targeted therapy in breast cancer. We don't see ASR mutation, we don't see HER2 mutation in this list. So PI3K mutations are very common, and as I say, now actionable. They are probably among the most common mutations if you exclude the ESR mutation, acquired mutations. They are present in 30% of the breast cancer cases, 34.5% hormone receptor positive. The majority are missense mutation in the kinase domain, exon 21, particularly the variant identified as PH1047R. This accounts for 50% of the PI3K mutated breast cancer. Others are present in exon 10, and in general, these are very commonly seen in a metastatic as well as in primary breast cancer. As I said, alpelisib has been, or Piqray has been the first drug approved for a PI3K mutated tumor, and this is the result of the SOLAR-1 study. It's a phase 3 randomized, as everybody knows in the breast cancer world, that randomized patient to a treatment with alpelisib and fulvestrant versus the fulvestrant with placebo in 2 different cohorts, one for the mutated tumor and the other one for non-mutated cohort. This particular test should have been done in the archival of fresh tumor tissue, even though patients had also the opportunity to collect cell-free DNA. We have seen the cell-free DNA data, but this was not the primary endpoint of the study. In fact, the primary endpoint was a PFS in PI3K mutating cohort locally assessed in the tissue. And secondary endpoint looking at overall survival, progression-free survival in both groups, the mutated and non-mutated, and also looking at the overall survival in the non-mutated. So you can see this is the first report that was published in the New England Journal, presented at ESMO, and clearly suggested that alpelisib improved the progression-free survival in the mutated group tissue analysis. And as you notice from the list of treatment where patients were previously exposed, there was a small group of patients that were exposed to prior CDK4/6, and that therefore this has become somewhat the standard for patient progressing CDK4/6 in our PI3K mutations. So this is a case of patient of mine that I've seen for the first time when she was being treated and then recurred for inflammatory breast cancer. Her original diagnosis was at the age of 43 in 2009. She had a ER/PR positive, HER2 positive inflammatory breast cancer, received standard neoadjuvant therapy, had residual disease in breast and lymph node. Then she developed shortly thereafter a biopsy-proven lung and liver lesions. So when she came to me, then she went through a number of different therapies, HER2 targeted therapy primarily. Then she came here at Northwestern, and Foundation 1 was run at that time, and she had a PI3K mutation identified. You can see she has also later on identified the same variant in the cell-free DNA. So she was enrolled in a clinical trial using alpelisib and T-DM1. And she had a dramatic response, as you can see in the middle CT, with evidence also disappearance of the variant, PI3K variant in the cell-free DNA, indicating not only a radiological, but also a molecular response. Eventually, she progressed, as you can see, without changing in the molecular feature of a disease. The 2 variants are P53, PI3K, and of course, as you remember, she has already amplification HER2. At that time, alpelisib was not approved. She was out of the study, so she was treated with the chemotherapy everolimus. Again, she had a molecular response as well as a radiological response. And this is a dramatic response seen on the PET-CT. Today, she's now on alpelisib. As we know, this is approved. As I say, fulvestrant and Herceptin, she continued to do very well. The PET-CT show no evidence of disease, and the cell-free DNA that is not detectable, indicating also a complete molecular response. This is a second case, interesting for a number of features that will become clear very soon. This is a patient, de novo stage 4 breast cancer, presenting with almost inflammatory breast cancer features. She had changes very early on in her breast. They were essentially not noticed, also because of the location of the tumor. Eventually, she underwent a core biopsy and a skin biopsy, and it was clear that she had an invasive ductal carcinoma, strongly ERPR positive, HER2 negative, Ki67 15%. She had bone metastasis at the time of diagnosis. When she came to me, we also ran cell-free DNA. She had the most common variant of PI3K mutation with 66% allele frequency. So at that time, of course, there is no treatment different from a CDK4/6. In April 2016, it was just 1 year after the approval of Ibrance. So she was started with letrozole and Ibrance at the usual dose. And also received some palliative pelvic XRT because of pain. Interesting enough, she actually ended the hospital with neutropenic fever and neutropenia, and she had to be dose reduced all the way to 75 milligrams a day. And you know, this is not usual. So eventually she had another cell-free DNA. You see the dramatic decrease in the allele frequency of the PI3K variant in the cell-free DNA. But now you start noticing also IDH1, 7.5% allele frequency. And we didn't pay too much attention, but we start to look at this very seriously because it was clearly something that is not related to our breast cancer. So what do we know about the dynamic of cell-free DNA, in particular cloning selection? Well, we have published with O'Leary and Dr. Turner a publication showing that even on day 15, the allele frequency decreases of the PI3K mutant indicate a response. And this appears to be more common in the palbociclib fulvestrant group compared to the fulvestrant placebo. Therefore, we expected that we knew that this patient was responding simply looking at the cell-free DNA dynamics with regard to the PI3K variant. So she responded for quite a long time. Eventually, she had progressive disease, and you can see that she has now a lymph node in the axillary region, the same side. So we did a tissue biopsy. It came out that she had an ESR mutation that appeared and, of course, confirmed the PI3K mutations already demonstrated in prior study. Now you look at this onset of very low allele frequency of ESR mutation, the Y537S. I think we need to start to pay attention to the variants because this eventually will represent even more actionable mutations in the future. And then we start to see again a continuous increase in the allele frequency IDH1. So the patient was started fulvestrant, assuming at that time, back in 2018, that this was the appropriate course of action. We published later on a study looking at the different mutations in the cell-free DNA at the end of treatment or progression. And we showed that essentially in the Paloma tree, the most common mutations were ESR mutation that increase in terms of frequency at the end of treatment, as well as PI3K mutation. And when we look at the variants, we show that in fact, this Y537S is the one that is present in significant numbers, much more than the D538G, in patients exposed with fulvestrant, of course, indicating that maybe this is appearing during fulvestrant treatment, and therefore we can assume that this is a resistance to fulvestrant. So with this knowledge, actually went back, and the patient showed that did not respond to the treatment with fulvestrant. So she had not only an ESR mutation, but yes, one variant that may suggest resistance to fulvestrant. So she had to go into chemotherapy treatment, and she received a number of chemotherapy treatments. She also got alpelisib, didn't tolerate very well, again, because of the PI3K mutations, and Zoloda. So eventually we had to do something about these IDH mutations. We sent to the hematologist, we did a bone marrow aspirate, and here we are, in the bone marrow, there is the same variant that has been identified with the cell-free DNA, clearly not related to our breast cancer. And IDH1, I'm not an hematologist, but Dr. Kurzer can tell you that has been associated with myelodysplastic syndrome. This patient eventually developed secondary AML. Patient is now relocated in Caroline, and she's seen an hematologist. And we'll follow up very closely to really find out what will happen to this other disease that she may be in need of treatment. So I think this was very important to show that, in fact, not only the disease evolves over time, but also that you can identify other diseases, other mutations, other actionable mutations in a patient using cell-free DNA over time in a longitudinal fashion. This was over a course of 3.5 years. So let's look now at the molecular evolution versus clinical progression. What happens if we actually detect evidence of progression at the molecular level, but we don't see a clinical progression? Do we have enough knowledge to modify our treatment in order to prevent further damage to the patient's future? So this is a woman that came to us and had a partial retinal mastectomy. She was actually 55. And the pathology showed that she had a primary tumor that probably will require endocrine therapy plus or minus chemotherapy. She had an oncotype intermediate grade of recurrence score of 22. So she was sent for radiation. And during the simulation, it was clear that she had some changes in the spine, eventually suggesting that she needed staging, and the staging suggests widespread metastatic disease. She was asymptomatic. So now we have a de novo stage 4 that had already surgery, strong ERPR positive, perfect candidate for Ibrance letrozole. And we did not have any additional tissue except for the primary tumor. And we decided we wanted to continue to monitor this patient at the molecular level with Garden every 3 months. So we have the evolution. She responded very well. The bone scan almost normalized. And during this treatment, at some point, she has the onset of this ESR538G. I showed you before, this is one of the variants associated with developer resistance to endocrine therapy, to high, but it's not been clearly associated to resistance to fulvestrant. So we did a staging at this particular situation, and she had negative imaging, meaning that bone scan was not active anymore. So now we have a molecular progression, and we don't have an anatomical progression. So we decided to start Faslodex. Again, a mutation was not associated with resistance for what we knew. And now the frequency of this mutation disappeared. The point it is no longer detectable. And so the patient continues to do very well. She had another non-detectable at this point, and clearly indicated that we can change or we can modify the patient progression at some point, especially if we have actionable mutations. And very soon you will know that there is a clinical trial actually looking at acting before the patient develop clinical progression in order to see if this may change the progression of his survival, eventually the survival, and this may have an impact even on studies in very early phases. So let's look at a case that we were all very surprised at the molecular tumor board because it was unusual, but not impossible. And these targets may appear actually in metastatic breast cancer. In some unusual case of metastatic breast cancer, and being reported that maybe these cases may have a prolongation of survival. So this is a patient who had an unusual disease. Remember, breast cancer can be very unusual. It's not really black and white all the time. So she had, in spite of having a breast cancer that was hormone receptor positive, she had in fact a very aggressive disease presented with metastatic disease in lung node and also in the spine. Well, she came to me with a wheelchair, and they had a soft tissue biopsy. There was a spinal mass that showed a poorly differentiated adenocarcinoma compatible with breast cancer, and this was a triple negative breast cancer confirmed also by NGS. So she had a triple negative breast cancer, a primary tumor that is hormone receptor positive, needed to be treated with combination chemotherapy upfront, needed to receive palliative radiation. And when she had a major response, then we went on starting essentially with alternating endocrine therapy, which she had minimal response most of the time, and targeted therapy. This was PD-L1 positive. She received also Pembro. Then she went on Doxil and back to abemaciclib. She went to progress through each and every one, and she had a large number of Garden testing. So this is the most recent progression back at the beginning of the year, where she started to have pain again. particularly because of back pain, shoulder pain, and lymphonodular disease. And you see, this is the new garden suggesting that, in fact, she has more tumor burden. But you can look at this new finding, this fusion, FGFR2 fusion, that appears now, and this is completely new for breast cancer patients. Definitely in her history didn't match. So this is a fusion FGFR2 SHTN1 genes, apparently from preclinical work, appear to be increase in phosphorylation of some proteins on the mTOR pathway, like S6, AKT, and mTOR. And so there is a gain function of this protein, and this has been identified in other tumor types, like cholangiocarcinoma and non-small cell lung cancer. And in fact, in cholangiocarcinoma, this drug, pemigatinib, or Pemazyre, has been approved for patients with this particular type of fusion and similar fusions. Due to the FIGHT 202 trial result, that show an incredible overall response rate, including minimal complete response, indicating activity in a tumor where otherwise there is not much activity. So she started the treatment in February, and you can see that the frequency of this fusion decreased dramatically. After 1 week, she felt an improvement in her pain, in her shoulder pain. And we were also monitoring CTCs, and she started at that time, before starting the treatment, under CTC, and with 2 CTCs at the end of cycle 1, I'm sorry, beginning of cycle 2. So clearly suggesting that she was having a dramatic response. More dramatic was actually the PET CT between February and April 2021, when she had completed now 4 cycles of therapy, where there is almost a complete resolution of liver disease, bone disease, with some persistent lymphnodal disease, indicating that she is really having a major response, minimal hyperphosphatemia. Otherwise, the treatment is very well tolerated, and the patient, as I say, is now asymptomatic. So in conclusions, I think I show you that molecular testing in advanced breast cancer is important, is increasing our understanding of disease progression and treatment resistance. I cannot imagine that we can practice in advanced breast cancer today without using molecular testing. And it's important to realize that tissue and blood-based diagnostics are doing different things. And they may be complementary. They may identify molecular alteration at baseline, but most important, if you want to understand progression and treatment resistance, you must use cell-free DNA. It's very relevant to this group. Also understand that the report doesn't give you all the important findings, and particularly doesn't help always to implement a plan. So you really need the interpretation of the molecular tumor board. There's a critical role in the implementation of precision oncology, because the choices may be different. FDA approved off-label drugs, as I just showed you, or may reach clinical trial. If you have a chance, if you have the opportunity, if you're lucky enough to have a clinical trial for targeted agents in your institution, in your area. So I think the integration of molecular clinical data generate this real-world information important about the important impact of precision oncology. At our institution, we created essentially a prospective clinical trial, a registry study, for which every patient is molecular test, agree in sharing data, and also continue accumulation of clinical data, so we can go back, look at the clinical information, structure the clinical information, match with the molecular data over time, and come up with guidelines inside or outside, and publish information that may be relevant to the overall field. So obviously this is an effort of a team. You need to put together a team that is able to look at this from many multiple angles. We have specialists in the phase 1 group, Dr. Che, Dr. Malinga. Very important, you have a molecular pathologist part of the group, Amir Bedad, that collaborates with me, running the molecular tumor board and review the data. We have bioinformaticians, genetic counselors, and of course the team of scientists as well as clinicians in the community. They're really interested in the commitment of the cancer center, the institution where you work. So I hope this was helpful. Of course, I remain available for any question in the discussion during the meeting, and thank you very much.
Thank you so much, Professor Cristofanelli. That was a very enlightening talk, and the difference that a molecular tumor board can make in the lives of patients with metastatic breast cancer. We have quite a few questions in the chat box. For want of time, I can't take all of them, but I'll pick and choose and see which ones I will direct to the speaker. So let's start with this couple of questions together. Do you do ctDNA testing in all patients with metastatic breast cancer? Do you do broad panel sequencing in all patients with metastatic breast cancer in the clinic? This is off a clinical.
Yeah, that's a good question. First of all, thank you for inviting me. Obviously, this is a great meeting. It's going to give you the opportunity to understand the importance of precision oncology, molecular tumor board, and teamwork in order to find the best therapy for patients. So when do we, this is a very common question that we get all the time when we present cases of breast cancer. As I say, breast cancer is not a tumor where we naturally think about molecular medicine and precision oncology, but the evolution of data is clearly indicated that it's important to use this test. I think in hormone receptor positive breast cancer at progression, you must use cell-free DNA. We've seen the data on ESR mutations, a PI3K mutation. We have targeted therapy. This patient may progress after endocrine therapy with an aromatase inhibitor, or may progress having had chemotherapy and endocrine therapy. After a few years, maybe they had already high recurrence score or intermediate recurrence score. So there is evidence that a biological feature of the disease is important in the decision planning and definitely in the monitoring. I think in the triple negative breast cancer, we can discuss when you present one of your cases. There are some opportunity for clinical trial as well as to put the data in the context of the standard treatment. It's clear that patient with triple negative PD-L1 positive will receive immunotherapy. As we know, sometimes cell-free DNA can be a measure of tumor burden, and immunotherapy can cause pseudo progression. So I think there are more data indicating that cell-free DNA can also be used as a monitor of tumor burden in the context of the disease. So for this in triple negative, and there are some companies that actually trying to test their technology in this particular setting just to measure response based on the tumor burden and the detection method. And clearly the resistance pattern in HER2-positive disease, as you know, there are studies looking at PI3K pathway in combination with HER2-targeted therapy, because PI3K mutation can be a pattern of resistance. But this is not the setting where you will do immediately cell-free DNA in a patient with HER2-positive disease, simply because we have very effective therapy, second or third line therapy. So I would say the most common are ER-positive, followed by triple negative, and I like to use in the longitudinal model in some cases HER2-positive as well.
What about tissue testing?
Well, tissue testing, first of all, every time that you do the tissue, that you do a biopsy, you need to send for tissue analysis. In a couple of cases, I didn't have time to present. Some tumors were not shedding. So the only way to really get information was actually NGS or the tissue. So I think a baseline, first recurrence, is important to do tissue analysis. As you know, sometimes there is a quality of tissue, what type of biopsy you have. You cannot do bone biopsy. Sometimes if you have a lung biopsy with an FNA or a small biopsy, there is not enough tissue. You go for the tissue for the NGS, but you do have a reflex approach like you had in lung cancer. Try to use the cell-free DNA at the same time to see which one give you the information that you need for treatment selection. And going back to the original question, to use in the clinic, I use Garden, I use a panel because usually it's more comprehensive, 74 genes. I think you can go ahead and probably develop smaller panel for the clinic, and that will be probably cover the most common genes that you need to know for your treatment planning.
Great. I think one other question is, what do you do when you find a PIK3CA and a HER2 amplification in the same patient? How do you treat this? You showed one of your cases also, but I think there's the question again in the chat box.
There's HER2 amplification, obviously, is the driver, right? As I said, you need to choose your approved therapies. In this case, the HER2 targeted therapy is the one that you use. But when you have developed resistance, you have a PI3K mutation, you need to go after the resistant mutation. Clearly, the PI3K mutation plays a role in the resistance to HER2 targeted therapy. In that case, I wanted to show just to identify a tumor where PI3K mutation was a driving mutation along the amplification, and she has progressed to a number of different HER2 targeted therapy. Even though at that time we didn't have that number of approved targeted therapy, we try as much as possible And you can see that the patient, in fact, progressed through. And the only treatment that where she had really a beneficial effect was the alpelisib, the everolimus, and now back to alpelisib. So clearly that gene and that mutation plays a significant role in some patients, HER2 positive. But clearly you have to go to the HER2 targeted therapy first and go to the different line of therapy. Trying to understand the resistance in the specific case may be dependent on a PI3K mutation.
Right. So the other question is, if a patient is detected with ESR1 mutation, is it advisable to stop hormones? I think Dr. Ghosh means an AI. I'm assuming that's what she means. So
yeah, I think definitely is advisable. There's overwhelming data indicating that the ESR mutation appears as a result of the low estrogen induced by aromatase inhibitors, and in some cases even with other type of endocrine therapy. So there will be extreme resistant to AI, so you cannot cross from one AI and another. I think this came in the past when we're using data from Bolero-2 and so that you can switch from an AI to a different AI with everolimus, but if you have an ESR mutation, that would not be effective strategy. Essentially, you will be treated just with everolimus. So you stop. Right now, the only drug that we have is Faslodex, but there are a number of studies looking at ESR targeted therapy with new SERDs, and I think these are the evolution of endocrine therapy, the path in the future. There will be a few posters presented at ASCO starting tomorrow, and I think these compounds are now in phase 3, so some of them hopefully will be approved. So we have better choices for this patient with ESR-driven mutations.
okay, one last question before we move on. What is the best, is it biopsy sample or CTC sample?
So the CTCs are complementary to the cell-free DNA. I think there are a number of studies that we and others have shown when you have a high CTC, you have the worst outcome. We have also a number of variants associated with the cell-free DNA, indicating the more aggressive molecular disease is also associated with high CTCs. Now, with the CTC, you can also do some molecular testing, just that the process is longer, so they're more practical to do certainly cell-free DNA. But I think CTC will come back because in some cases, as I show you, you're not sure what the mutation is coming from the tumor, is coming from the patient DNA, and some tumors are not shedding. Interesting enough, the tumors that are not shedding may still have CTCs, and CTC can actually complement the information that you have in these few small cases where there is no evidence of cell-free DNA. I didn't have time to present some cases, but in general, the CTC are more common in patients with bone metastasis, while the cell-free DNA is more common in patients with visceral metastasis. So I think the two can cover almost 100% of the cases.
Great. So it's 6:40 now. Thank you so much for patiently answering all our questions, Professor Cristofanelli.